Can everybody hear through this mic okay? No? How about now? We're very excited to have Dr. Mesa here with us this evening, talking about prolotherapy and PRP. And prolotherapy has been around and published 1958. And my first exposure to it was when I was in my residency in Norway in 1979. So it's not well documented as a procedure because they're using sugar, and sugar doesn't cost too much. So the drug companies don't make a lot of money on it to put the research behind the benefits of it. But I saw numerous patients in Norway who were having their training done in the way that we do a lot like we do in Folsom, but they needed the added help of some procedure to help get the ligaments that were oftentimes stretched out in their lumbar area or cervical area to be more stable. And they didn't want to undergo fusion. So this was a very nice alternative, but to be used in conjunction with exercise. So when I returned to the States, it was pretty important to me to try to find some alignment with a physician that would do prolotherapy. And there was one that we had a long-term relationship in the Bay Area that people have a long ways to go. After that, Dr. De Mesa joined the UCD Pain Fellowship Program, and I was very excited when I learned that he was a doctor of osteopathy and had trained at the Mecca of osteopathy, which is in Kirksville, Missouri. And if you know anything about the osteopathic profession, it is a very manual therapy oriented profession from its birth. And he trained at the medical school where it all started, and told me that in his curriculum they had a manual therapy course every quarter of the school term that he was there for 4 years. So we had that great bond of manual therapy, plus his strong interest to do prolotherapy. And tonight, we're very blessed to have him here, talking to all of you and letting you know about this procedure and PRP that could be very helpful to somebody that is trying to get and manage their back pain, and exercise sometimes is just not quite enough.
Thank you, Michael, for the wonderful introduction. And thank you all for having me. It's a great pleasure to be back up here. I think Michael said some really key things here, is that this is something that is synergistic with exercise. So it should not be viewed as just a singular therapy, but it is something that should be used in conjunction with your physical therapy home exercises. I'm going to talk to you a little bit more in depth about what prolotherapy is, as well as platelet-rich plasma. I'm going to speak specifically on spinal conditions because a lot of people do have back pain and neck pain and other areas. But this, this can apply to many other areas of the body, including the knee, the elbow, etc. So any musculoskeletal condition, people can benefit from these treatments. So I'm going to kind of forward here. I have no disclosures or conflicts of interest here. And so here are some of the learning objectives. So number one is, first, recognize the importance of structure and function. So form is related to function and vice versa. They're interrelated. When we talk about treatments that aid people to get better, we comprise the thought or the categorization of treatments as orthobiologics because they can either be cells, they could be things like platelets, they can even be things like dextrose, which aim to help to regenerate or restore tissue. And so they play a very important role in wound healing. And we see this in terms of their effect on inflammatory cytokines through through the use of growth or through the this signaling of growth factors. And so prolotherapy and PRP are within that spectrum of orthobiologic treatments. Other things you might have heard about are mesenchymal stem cells, right? Cells that you remove from your bone marrow or even fat. The next learning objective is to look at how wound healing is important, and little feedback here. How wound healing is important in our understanding of the practical applications. Thank you, Michael. Practical applications of. Say it again. The practical applications of the treatment, and then finally examining the use of prolotherapy in each of these conditions. Okay. Okay. Is that better? Yeah. Less feedback? Yeah. Okay. So Michael was alluding to the history of prolotherapy. Would you know, like 400 BC, Hippocrates actually had used a hot poker to burn the axilla of an individual, and that was the first time that people thought about, hey, is there a possibility of sclerosing or causing some sort of irritant or damage to a tissue, but then it would eventually help in terms of regenerative potential. And then fast forward to some key physicians, Hemwall, Hackett, and Patterson, who really started the foundation and development of the use and practical application of prolotherapy in the United States. This was something largely used to treat individuals in service, as well as those that were suffering from musculoskeletal conditions, whether it be tendon injuries, ligaments, and so forth. In terms of use of this, you can notice that there's a lot of not only individuals in medical practice, but even in the veterinary practices that also utilize prolotherapy for different ailments, okay? And suffice it to say, it's not just ligaments, tendons, it's also things like joints, so arthritic joints. These are other applications. And as you can see from the list of things, it is quite international. Michael had mentioned Norway, but this extends beyond that, even in some of the Asian countries, and we use it in many different ways. We even address the fascia, which we're learning is incredibly important. So prolotherapy injections. Pro-life, proliferate, regenerate, or give life to. So prolo is a larger term, but we often use dextrose as the solution for prolotherapy. It is non-surgical, and by injecting dextrose into damaged tissues, what we find is that it actually creates an irritant effect, and that irritant effect then creates signaling. And the signaling, sorry, I wish I could decrease the feedback. Do you think it's because this other, yeah, let me try and move this one down. But then it might not capture on the other one, but that's okay. Yeah. This one? Like your belt and put the other mic higher. This one higher? Opposite. Oh, like this? Yep, there you go. Okay. Is that better? Yay. Okay. Now we're back on track. So essentially, injecting the dextrose actually creates a signaling cascade. And that signaling cascade is what is important in creating a focal inflammatory response, but then long-term creating an anti-inflammatory response. In the same fashion, it also stimulates the area that is injected to become stronger. And I'll show an illustration or a picture of that. Prolotherapy is safe when you're comparing it to other surgical procedures. It's sugar, so if you're comparing it to something like a corticosteroid injection or a cortisone injection, there is less side effects, right? Because there's a whole host of systemic side effects from cortisone, right? Some people get higher systolic blood pressures, they get high blood glucose sugar levels, particularly if you are diabetic. Other people have mood instability, irritability. Some people it'll flip into mania if they have underlying depression. Aside from that, it can cause sleep disturbance, insomnia, etc. So there's a lot of different problems related to this. And you might have noticed that if you've ever gotten an epidural steroid injection or something like that. It's simple, and it's basically, you just inject the dextrose, you dilute the concentration that you have, and you inject it into the damaged tissue or the tissue that needs support. Good clinical outcomes for selected indications, and furthermore, very cost effective. What about platelet-rich plasma? Well, what is platelet-rich plasma? So platelets, if you think about if you have a cut or a wound, platelets go there, and fibrin goes there, and then it forms a clot, and it heals. And after it heals, the scab falls off, and your tissue is back to where it was beforehand. And so platelets, very similarly, also create this signaling cascade. And it also results in stimulating growth factors. Growth factors are very important in pain reduction and decreasing inflammation and creating what's called angiogenesis. That means increasing the blood vessel supply. This way that area can really begin the process of healing. You need blood flow, you need oxygen, you need nutrients to get to an area in order for it to heal. So platelet-rich plasma actually satisfies each of these criteria. And so you could see that it could do it by reducing inflammation, improving the regenerative potential, and then also improving function. So we see this often. Platelets, we talked a little bit about the history of prolotherapy, dextrose prolotherapy. With platelets, these have largely been used also over decades, and some of the applications you might notice are in fields like maxillofacial surgery, dentistry, where they're now, rather than using lots of anesthesia and lots of other agents to try to stimulate healing, they'll actually use platelets. Other applications are even when people end up getting surgery, they still will also get platelets placed in the surgical field or where they had surgery to promote healing. Sometimes they use bone marrow, but a lot of times they'll use platelet-rich plasma. Some people might notice it in the cosmesis industry, right? That they call PRP facial, so it also helps with like skin issues, and so orthopedic applications has become more and more favorable, and we'll talk the reasons why, right? We talked about some of them, but we'll get to more. This is the important information about the growth factors. Growth factors are very, very important, and that's the whole reason why people utilize platelet-rich plasma. Next is, what is wound healing, right? Like you have an injury, why are we talking about wound healing so much? It's because a lot of the pain that you have as all of us age is due to weakness, and the weakness is typically in the well. And what do I mean by that? I mean, it's in the structures that try to stabilize or hold things together. And a lot of times, those are things that we don't often think about. We always think about maybe, the discs in terms of the back or the facet joints, but there's actually even the ligaments. We have lots and lots of ligaments that hold our spine and our bodies together. We have lots of muscles, and we have lots of tendons that connect to different areas. So these are all potential multi-targets for prolotherapy and platelet-rich plasma, both of the orthobiologic solutions. So here is just depicting bones, right? Like we see bones here, but understand that there's layers upon layers of muscles and fascia. And fascia can be very tight and very strong, but it can also be very translucent and mobile and rich. And so we have to understand where this is all going to really understand how we can potentially improve our health, especially our back health, our spine health in general. So knowledge of the anatomy and the physical exam, listening to the patient, is as important, probably far more important than the actual intervention that one does. This here is an example on your left-hand side of a gluteal area and a thigh, right? If we were to look at that as to how it really looks, you'll notice there that that's the gluteal muscle. You see how organized and fibrous the muscle is, and then all of a sudden it turns into, or it connects and forms this aponeurosis of this very translucent structure. That's the fascia. And so all of this is mobile. All of them have nerve supply or innervation. They all have nerve endings and nerve fibers. So sometimes your pain that is in the back may radiate to the leg and it's not a nerve compression, and vice versa. Sometimes you could have hip pain and have back pain. You have to figure out where it's coming from. And sometimes the treatments are somewhat standardized and we never really get to the aim of what we're trying to fix. And you'll just go on this, you know, it almost feels like a rewards card for epidural steroid injections, or, you know, like you're coming back for your neck. And we're never really aiming to get to what we're hoping to do. Okay. So what are the processes of healing, wound healing? There are three major ones. So if you'll notice here, there's an inflammation phase. Then there's a phase called proliferation. Remember, prolotherapy? That's what it aims to do, is it gets it back into the proliferation phase. And then finally, there's what's called remodeling. So if you think about a contractor that comes in a home that may need some work done, maybe there's a chronic problem. The plumbing needs to be fixed, the roof needs to be. So the aim of these orthobiologics, things like prolotherapy and platelet-rich plasma, are as contractors. They will come in and they'll say, we need somebody to come in to work on floors. This roof needs 14 tiles repaired. This, you know, so they're signaling to all of these biological processes to aid in healing. That's only part of it, though. The other part of it is actually the exercise. And we're learning more and more about tendon health and ligament health in terms of isometrics and how that integrates and applies to improving in tensile strength and durability of tendons and ligaments, for example. So some people don't need help, and that's where we come in to offer these treatments, because they really do help stabilize those structures which are traditionally very weak. So if there's something bony and something attaches to it, it's probably important, right? Your elbow, important, right? Your you know, that PSIS right by your sacroiliac joint, very important. A lot of things connect to it. And so these areas tend to be the areas where there's weakness. The rotator cuff, the gluteus medius, right? And so these are targets, potential targets for treatment. And so in the remodeling phase, it brings it back to what is close to being as normal as possible, given our change in age, okay? So this is an example of the healing process. And here you can see it in slides, right? Inflammatory process is rather quick. It's usually within the first week. So if you have an acute disc herniation and inflammation, the best time to actually do said epidural injection is within the time that the disc has herniated and there are, you know, interleukin 6 and, you know, TGF alpha, like where there's actually inflammation irritating the nerve root. When you do it outside of the window for that, it's not always the best thing to do. And that's where you match the treatment strategy with the timing of injury. So if you have a chronic disc herniation and you have chronic changes to your disc and your facet joints, you know, steroids may not always be the best answer. It may actually be something like prolotherapy or something like PRP, which it aims to treat it and meet it at its appropriate stage, okay? So this is why it is so important to understand a little bit about wound healing and inflammation, and understanding that there are the 4 R's: repair, replace, restore, and regenerate. And understand that with these treatments, the more injury that occurs, the more remodeling that happens. And almost like a corroded pipe, right? You just kind of see that it's just kind of built in, that, you know, water's not going through so well. And worse, there's nerve fiber ingrowth. So those nerve fiber endings are painful, and they just get more and more painful with movement, okay? So inflammation, though, is necessary for healing. That's why prolotherapy, it doesn't always feel good right away. PRP, it doesn't always feel good right away. When you have a cut and platelets are going in there to try to heal something, it doesn't feel good right away. But it goes through stages, and then eventually you feel better. And that's what we find is that the inflammation, it's like a longer term anti-inflammation for the long game. And that happens in a cascading pattern. And you notice that there's this Venn diagram, right? Like, it's not just all inflammation is here and there's this hard and fast black and white where you then cross over. But there are stages that go back and forth, so it's in flux. But generally speaking, we have all of those three processes: inflammation, proliferation, remodeling occurring. And this occurs over time. So on the order, with inflammation, on the order of a couple weeks, proliferation, maybe a couple months, and then remodeling, 3 to 6 months. That's what we see. And so don't be discouraged if you get an injection of PRP or Prolotherapy and you're not noticing immediate results, because we're not expecting that. I always manage the expectations for patients to understand that. We see an improvement after about 3 to 6 months, and it persists. And that's what we see even in the spine literature. So Prolotherapy and PRP, helpful for chronic injuries, right? Gradual, insidious, overuse injuries like, shoulder, neck injuries, low back injuries, and arthritis. This is just a little bit of an understanding of tendons, right? So when we look at tendons and they rupture, they look different under the microscope. So you can't treat something that is fundamentally different in composition with the same treatment. So here, I'm just going to use the logical extremes, right? So here we have intact tendons. They look like a paint strip, right? It's very organized. It's just straight across. Look at an acute rupture and look at chronic ruptures. They look different, right? Just from a glancing. And certainly look at tendinopathy, which is a long-term sort of chronic injury over time. That looks vastly different from an acute rupture. So the treatment has to be different. You can't apply the same standard for different types of pathology, even within the same structure of a tendon. You have to understand the timing of things. Prolotherapy effect, right? The Norway example of like, wow, these people are getting better. Why are they getting better? They're actually getting stronger. On this is an example of a rabbit tendon. So on the left, the very first stick-like structure, if you will, it's actually a tendon, is a control at 9 months. On the right side of it is it injected with dextrose, and you see it's proliferated. What does it look like? It's thicker, right? It's much thicker, right? Then you look at it 12 months. The tendons on the right reveal an increase in diameter of about 40%. This is injected with dextrose, right? And then so it's estimated to double the strength of the tendon. So that's really important because sometimes as we age, we just don't have the composition to be able to build that on our own. And so prolotherapy aids in that, yet we have to meet it halfway with the exercise to be able to do that. So this is an example of how, and look, it's on the order of 9 months. It's not gonna happen in 9 days, right? And sometimes we fall into the trap of, hey, cortisone, I'm feeling great 3 days after, a week, but then you start getting into like the month, and then you're just not noticing a good benefit. And worse, your tendons or your ligaments or your joints or other things are now are weakened in a sense. So be very careful about that, and repetitive injection treatments. Indications, so we talked about chronic conditions, also prehabilitation. You can use it for that. If you're going to be getting some form of surgery, you can use some of these treatments because they're non-cortisone based. So they're going to help aid before you even get a procedure done, as an example, as a means to prevent surgery or bridge to surgery. Post-surgical, if there's poor healing. I had a patient who had an implant. They put in an SI joint fusion implant, and it backed out. And so the tissue was damaged. The gluteus medius was damaged. So I told my colleague who had referred the patient to me with that implant, I said, you need to pull the implant out because it's in the skin, but what I'm going to do for you is we'll do PRP in and around this implantable, you know, where this construct had come out. So we injected it after he did the explant of that device, he didn't explant the device, he actually pushed the device into the bone where it belonged in the first place. We looked under ultrasound at her tissue afterwards, and it looked great. And she recovered better after the surgery because she got PRP before the surgery. So it's just an example of one of the indications or uses. So same thing with spine conditions. You can help it with degenerative spine. Contraindications, cancer, bleeding disorders typically. You know, we don't typically use the treatment for that. If you have a lot of liver dysfunction and other things, systemic inflammation, pain all over, not, you know, this is not going to always be something that can be helpful. Okay, I'm going to pause here for questions, and then we'll get into some of the data. Anybody have any questions right now? We're going to pause here.
Well,
Yeah.
actually,
Yes.
I'm curious about how you arrived at sugar. How did that?
Yeah, well, you know, I don't know you know, they use different sclerosing agents in the past, but they found that sugar tend to have a hyperosmotic. So remember in biology class when you kind of had, you know, like something with a solute, like it was like much more concentrated, and then you put it next to something else, and then it just sucked out all of the water out of that something else. That's what happens with dextrose. So if you take dextrose, it's very highly concentrated. What do I mean by that? Dextrose comes typically in a 50% solution. So we dilute that, but it's still pretty high, diluted to about 15%. So when you inject that into a tissue or somewhere else, it draws out the water in those damaged cells. When those cells are dried out, it goes through a process called cell apoptosis. So the cell dies. In dying, it releases a lot of factors that say to the rest of the region, you know, help, you know, I'm getting inflamed, I need life. So then pro-life comes in, right? So then all of those other processes or those cell signal processes come about, and then that's what aids in the strength of that tendon, as well as or ligament, you know, in the case of the SI joint and the lumbar spine, as well as the remodeling that occurs. And you can actually see it under ultrasound. It's kind of gets thick, you know, so it's nice because you can avoid fusion in some cases, which, again, that's a metallic. Some people get metallosis, or there's a lot of complications that can arise with surgery, whereas this is very low risk, if done in the right hands, obviously. Yes?
So, with that, the plasma, what do you actually, two questions about that.
Yeah.
When you do the plasma treatment, what actually are you inserting? Sugar one, I understand.
Yeah.
And how do you know whatever injury you have, which one to use?
Good question. So I'm going to repeat the question because that was given for feedback in the past. Is I understand what sugar water does. That was explained. But what about the plasma? Like, how does that work? Or how do we actually utilize that? And how do you decide what to use? And so one thing to know is how do you prepare it? And one of the reasons why platelet-rich plasma and prolotherapy are out-of-pocket expenses, unfortunately, is because number one is the funding sources, the lack of research, and the lack of drive to research, because it's not a device, or it's not an implant or a screw or something. Well, the platelets have to be prepared, and so we remove blood. Just like you get your blood, you know, your CBC, your doctor sees you and they say, hey, we need some blood, and check your blood labs. So we remove the blood. We then centrifuge it. And usually it's at a certain amount, like say 2,400 or 3,400 rotations per minute. And we keep spinning that for roughly 10 minutes, or if you want to do a double spin, you're basically removing and concentrating the platelets so that they become roughly 8 times, even 10 times in some cases, more concentrated than your typical platelets. So if you've ever seen on your labs, like it says, oh, my red blood cells, my white blood cells, hemoglobin, hematocrit, platelets. So whatever that platelet number is, think about that times 10. That's a lot, right? Like you can have billions of platelets. So what we've learned, at least in spine, is that the higher the concentration, the more the stronger the effect. Okay, so there are some studies or maybe some outcomes if you've gotten PRP and it hasn't quite worked or you got it a long time ago. What you'll see is some of the data reflect that in those studies where there are poor outcomes or not much greater than placebo, when you look at the methods, that's the important section to look at, the methodology, you'll see that it's 1.5 times. That's not 5 times, 10, 8 times, 10 times. That's an insufficient concentration of platelets. So there's great variability in the processing. So that influences the outcome, and that's why the literature is spread and a lot of insurance companies consider it investigational, is because people are doing it differently. So now people are more and more involved in getting registries where they kind of say, this is the standard I use, this is how I prepared the platelets, and this is what was injected. And I personally, I do that all the time, is I calculate how much so I know what you're getting, as opposed to, you know, just saying I did a platelet injection, okay? So I hope that answers the question. So you remove the platelets, or you remove the blood, you spin the blood, you concentrate the platelets, and you inject it into the damaged tissue. The data, it depends on what you're injecting. When you inject in the spine, what we find to be rather helpful is what we call leukocyte-rich platelet-rich plasma. And that tends to be very effective for a lot of folks. It does spur an inflammatory response, so it doesn't really feel good. You know, the injections, not that day maybe, but like the day after, several days later, you may feel a little bit sore for 3 days or so, and then you get better. You'll feel some stiffness too, okay? Yes, question?
Do you do both of these for SI joint dysfunction?
You can, and there's literature, well, I'll go through that, but just in fact, that's a good segue into this next piece here. So I'm gonna talk a little bit about prolotherapy and PRP for the spine. So here, this is a study where they looked at the sacroiliac joint. The sacroiliac joint is a joint beneath your low back that is comprised of the sacrum and the ilium. The joint is a space between two bones, but there's actually a ton of ligaments behind it, and there's two very important ones called the dorsal sacral interosseous ligament and the iliolumbar ligament. And in one of these studies, they actually looked at functional outcomes after injecting sacroiliac joint and looking at instability of that region. And what they found was those folks that actually got the treatment did really well. They even did a comparative study, not this particular study, but they looked at cortisone versus dextrose prolotherapy. And this is really crazy. So they took 2 groups of people. They gave bi-weekly injections for 3 weeks. So 3 injections, 1 week spread apart, or 2 weeks spread apart, I'm sorry. And one got whopping doses of cortisone, like probably triple the type that you get with your epidural, like that much. So on each occasion, so close to 240 milligrams of triamcinolone, I think. And then the other group just got sugar water. They compared these 2 groups. After 2 weeks, cortisone won, okay? After 15 months, the cortisone group, they didn't actually do any better. And 50% reduction in pain in over 60% of the individuals with dextrose prolotherapy. So one has higher risk, less reward long-term, good short-term gain, but how much more better short-term gain? Not incredibly high, you know, for the amount of steroid and the side effects that you get, it's not always, you know, a good thing, right? So you're still exposed to that. So with sacroiliac joint instability, we find that people that have lumbar spine conditions, you can stabilize this very fulcrum. The SI joint is like a very large facet joint on the bottom. And so if you stabilize that, you really manage a lot of the hip back pain area, or hip back pain syndrome, okay? So the use of prolotherapy, effective for the SI joint. PRP, slightly more effective when they did a comparative study, but that was a single study. They both can be very beneficial, okay? What about platelet-rich plasma? So the reason why I bring up platelet-rich plasma is because this has a little bit more literature and evidence for the degenerative spine. So where do you inject? Well, if you have disc-related pain, you can inject in the disc. So on the upper side of the screen here, you see a healthy disc, and then you see a degenerated disc. So PRP can be injected in the disc for discogenic pain. Where else can PRP be injected? It can be injected into the facet joints for arthritic kind of pain, and it can be made into what's called a lysate. Lysate, you could just think about it as PRP with lots and lots of growth factors, and that could be injected epidurally, so not a steroid, but in fact PRP injected epidurally, and into, not in the nerve, but around the nerve, and people get lower inflammation of their radicular pain with that. Lastly, you can inject PRP into the muscles. A lot of times, how many people have seen somebody or had maybe a parent that had knee arthritis? Knee arthritis, right? And so when the bone gets closer to the bone, what do you notice about the muscles of that individual that has knee arthritis? Is it big? Is it atrophied? Small? It shrinks, right? It shrinks. In fact, if they have one more than the other, that knee looks the muscles look particularly small. Same thing happens with your facet joints in your back. If you look at the muscles that are next to those joints and supplied by the same medial branch nerves, what you'll notice is they're replaced by fat. And so there was a study done by Hussein where they did serial injections of platelet-rich plasma, up to 6, and what they found was that, together with physical therapy and a little bit of walking, led to decrease in the fat. You see that? More atrophy, less atrophy. If the muscles of the back are strong, the support of the back is strong. Those are the deeper core muscles in the back. So it's a very helpful thing to be able to do. And so there was a more recent study in 2023 when they looked at platelet-rich plasma for the low back. And so these are over 2,600 individuals, 40 studies where they targeted those different things that I talked about, the disc, the facet joints, the nerves, and the ligaments in the muscles. And many people, and these studies were low risk of bias, so they threw out the studies that were maybe case reports or not really good information, right, that were gained, or suspect. And what they found was that people actually did very well, especially in things like the facet joints and even the discs. And there was very low risk. So in all of the studies for disc injection, there was only one discitis, like infection in the disc. The remainder people did well. Surprisingly, those people, they did well not just in 2 weeks or 2 years, they did well in 5 years, right? So they were able to, and the satisfaction rates were very high. They would do it again. Even the muscle injections, the satisfaction rates were upwards of 83% because they felt better, they were stronger. Same thing for the facet joints. They did some randomized trials looking at facet joints versus placebo, and they found similar circumstances that people did better with platelet-rich plasma. So level 2 evidence is stronger. The higher the level it is, the stronger the evidence. Level 4, poor, for example. And it was level 4 evidence as early as 2022. So fast forward to 2024, we're at level 2 evidence. Still not covered by insurance, but it should be approaching that area. Yeah.
In regard to all this research you're reporting,
Yeah.
how does the age factor
Yeah.
enter into this?
We actually find that people do, it's a good question. So the question was, in terms of these studies, how important does the age factor influence the study? I would say to you that if you measure your platelets, and you concentrate them and you know how much you have, sorry, I'm gonna try to walk around until it stops, then you're more than likely to still do well. Age doesn't necessarily matter. I would say to you that it may take multiple targets, right? It may take not just treating the disc alone, monotherapy. You might have to treat the disc because when the disc collapses, the response is on the back, the facet joints are loaded 4 to 8 times more because of the influence of what happened to the compressed disc. So you can't just treat the facet. You probably are better off treating both the disc and the facet. You hear the, so you have to treat it as a whole. And it may include PRP plus exercise plus prolotherapy, right? Because we're talking about the ligaments as well, not just the disc or the joints or the nerves. So combined, people can do really well. Same thing for disc. There's another study here where they looked at 4 centers across the U.S., total of 60 patients. They compared it against things like saline and an antibiotic, for example. And there's no added risk to doing the PRP injection, and a lot of people had done well. NRS just means the numeric rating scale. So like, what's your pain scale? Is it 10 or is it 5? And then ODI stands for the Oswestry Disability Index. So that's just a measure of function. Are you very disabled because of your back pain? So they measure these, they use standardized tools to then check as to whether or not the treatment helped or not. Okay, so people have also used intradiscal injection of PRP. The worst is intradiscal injection of cortisone. That actually caused a lot of side effects in many people, and that's why it's not done. They've tried different things, stem cell injections, all of the like, and some allogenic products, meaning those that were derived that people try to inject from other people or fabricated from other people, did not seem to work out in the data. But using your own bone marrow concentrate or using PRP seemed to be good in terms of the response. And that's the difference between autologous, so this is autologous means auto, myself, like your own blood removal or your own bone marrow removal. That tends to be safer. There's less of an allergic response because you're taking the best of you and injecting it into, not the worst of you, but the area that needs help, the area that needs help. And then the other is allogenic, is somebody else's. That is still yet very, it's hard because you may have a response to that, This here is looking at another prolotherapy review, systematic review and meta-analysis. It's kind of small, but what I'm going to show you here are the different graphs. And here, what you'll see is that, if that little black diamond falls on the left side, it indicates that prolotherapy or dexterous prolotherapy is better than the comparator. If it falls on the right side, it's roughly equal to the comparator. And so this was just one study, but it was a culmination or a composite study. And so Prolo did better than saline, than a placebo, when injected into musculoskeletal regions, including the sacroiliac joint, right, like sort of the spinal region. Prolotherapy did better than exercise when you looked at that pooled data. Prolotherapy was equal to PRP in these selected conditions. Remember now, they're comparing the two, not comparing PRP versus, like a placebo. It's actually head-to-head comparison of the two. And then Prolo is equivalent to steroid when they compared prolotherapy to steroid. So that, again, these are just studies where they pulled it together and then just came up with a computation. It's not to say that it really truly is better, it's just to say it's comparative to that in its response. Because we know, right, just because Prolo is better than exercise doesn't mean we should not do exercise, right? What it means is exercise plus Prolo plus PRP potentially, that, and plus or minus bone marrow concentrate if you really need some help, right? You really need true cellular therapy like stem cell therapy. That creates this synergistic effect. But the Folsom method actually, what we've noticed is, Prolo and exercise are good enough. That's good enough, especially when you're looking at cost affordability, right? Like platelet-rich plasma, there's a lot that goes into processing. BMC or bone marrow, that's a lot, right? I have to drill into your ileum, remove your bone marrow, concentrate the cells. So there's a lot of preparation in it. It's not as painful nowadays. You can actually do this, in an office setting, and it's very tolerable. In fact, people don't even, the next day, they don't even notice that they had a bone marrow aspirate because we use technology to help that process. And so these all are very useful because you can avoid the side effect risks of corticosteroids. And I'm not bashing corticosteroids. Remember, their use is good when there's an when there's an appropriate time frame of using it. But most of us all here, we have like chronic stuff, right? Like my back pain has hurt for many, many years, you know? And so this all aims for improved recovery, healing, and performance. And that's what we're looking at, right? We're looking at pain relief and improvement in quality of life. And so these are factors that can be very helpful. So orthobiologics, you have two examples here. Prolotherapy we love, and platelet-rich plasma, also very good. Very helpful for treating folks. Very safe. And clinical trials don't really show many adverse side effects, aside from here and there, like some people get a significant flare. Some of the injections, if they're injected in the wrong place, or some other people sometimes get like headache, or they get that one case of discitis, those can be very preventable by using sterile technique, the use of antibiotics, etc. There is insufficient evidence specific for Prolo to the spine, but we tend to see that it does really wonderfully for the sacroiliac joint, which is honestly is part of your spine, right? Like it's very helpful. And we've injected things like the iliolumbar ligament, which the SI joint connects to that L4, L5 region. So I've had great success injecting all of the ligaments of the lumbar spine in addition to just the sacroiliac joint. PRP, level of 2 evidence, recall, and that can be targeted in multimodal fashion. And also just a positive effect with baseline status, and patients may improve while mitigating risk. I'll pause here. Any questions from the crowd here? And I'll repeat them if you have it. Yes, you have a question.
I know over a period of time it takes to affect the effect.
Yeah.
But how often do those injections, how frequent are the injections?
It's a good question. So the question was, we know that over time it has its effect, but the question is, how frequent are the injections? So I'll talk first about prolotherapy, right? So many individuals with prolotherapy, they will do like weekly injections. Some go as far as 5 to 10 injections, almost every week. That's a lot. But if one were to understand the structure and function, form, function, and understand the body, what has happened, maybe what has been traumatized after a surgery, we can then understand a little bit more about what the targets are. And then we could use things like ultrasound to check microvascular flow to really see where are the injured tendons and ligaments. So then we target the place, but we don't do 5 to 10. Maybe we just do 3. Right, for sacroiliac joint prolotherapy as an example. So you don't need to do so many injections. You can do less and still get the same response if you are more precise. The other part is platelet-rich plasma. So we see that people that get a series tend to do better. Could you do one and get better? Yes, absolutely. But we find that a series tends to be better. There is no magic number. Some of these studies, they go up to even 6 injections for the muscle. Some just go up to 3. Others are just single injection. So it really is variable, but I would say to you that just generalizing, a series tends to be better, but after you get that series, and then you get the rehabilitation strategies for that lumbar spine, and you treat the whole issues, not just one or the other and little piecemeal. You just treat that given the individual examination, like what you're noticing on exam, then people don't need repeats, right? Like that disc study, for example, that's 5 years, right? And if you're treating the facet joints, people get long-term relief. There's a study 12 months, 24 months. So these are year-long studies. It's not acute. This is just because we know that if you were to do a PRP study or a prolotherapy study and you cut the study short and you say, okay, at 6 months, the corticosteroid did better. Well, it's not really getting its effect yet. right? Like not really getting its full effect. So these are long-term studies that people are doing better. So the decision as to whether to repeat PRP or prolotherapy is largely clinical. It's like, do I really need one right now at this point in time? Financially, does it make sense for me? You know, maybe I'm on fixed income. Maybe I'm feeling good. Maybe just the isometric exercises are helping. Or maybe I need really a lot of support right now. So I really do need these injections because it's going to be a scenario where the quality of life years missed by not being active and not being able to join a community in the gym, just such as here, Folsom, that's a detriment to my health. And so investing in that may make sense for me at this time. So I'll repeat it, you know, and for our younger individuals that are in athletics, they tend to get it fairly routine. Some actually get it before it becomes a problem, when they know that its embers are kind of coming, that, you know, this is coming, so let me just go ahead and treat it before it becomes a larger problem. So there's different ways, like I mentioned. You could do pre-surgical, you could do to avoid, you could do different things, but that's generally the consensus or the thought process. Yes?
Should patients continue regular physical therapy, especially with us, aquatics, ultrasound treatment?
Yeah.
Any recommendations?
So the question was, should people continue physical therapy? Because we have a multitude of modalities, aquatics, ultrasound, all of those things. And the answer is, yes, you can. I would say, though, there is a caveat or a detail in it, is when we do the injection, the return to activity is specific. So we really want you to rest for that first week because you're going to be sore. Remember, we're inciting an inflammatory response, a proliferative response. So for that first couple of weeks, you might be a little bit sore, so you're going to have less activity. After you've received the treatments or treatment, and after that 2 weeks has kind of come to fruition, you then begin the process of improving your flexibility because you may be stiff. So you can work on range of motion. After you work on range of motion, you then begin doing things like the isometric exercises for the low back, for example. And after isometrics, then you progress to gradual strength, right? You're getting back to strength training. And it's best to do it with physical therapy because they could be the outside observer to make sure your technique is still good, because now we're re-injuring, if you will, or re-stimulating the area which has already been damaged. And so we want to make sure that there are corrective factors in terms of how you're actually progressing with therapy and that your technique is still good, right? Because if you do, I'm just going to use a very obvious example. If we do a platelet injection, which hurts, into your Achilles tendon, you're not going to be able to use that like right away. It's really, really painful and it hurts. And after though, then you could range it a little bit better, and then you could start doing a little bit of isometric strength, and then you can strengthen, right? So there's a progression of it, and as long as there's communication between the physician, the therapist, all of that is fine. We try not to use so much other modalities during that time frame, like immediately after. We just let it do its thing. The most important thing is not to actually take non-steroidal anti-inflammatories during the course of the treatment, whether it be prolotherapy or PRP. And the reason is because you're negating the effect of that which you are trying to achieve. Okay, we want these things to be strong. We want it to take its effect. As they say, sometimes when you're dealing with a situation, it's going to hurt. And if you go in with that expectation, knowing that this will be painful for a little bit of time, but it's not going to be for the whole time. There is that light. And so understanding that is very helpful. And understanding too that, again, it's not a failure if after 2 months you're not really feeling, right? Because you know that it's going to get better. That said, with prolotherapy, the effect can be very rapid. So if you do well with the first injection of prolotherapy, traditionally, and this is very much supported by a paper by Hoffman in terms of sacroiliac joint response, the sensitivity and specificity is around 88 and 92% respectively. Like if you respond favorably to that first injection, you're probably going to do well. So then I rapidly kind of get you back to doing the second injection and then maybe a third injection. If you're not doing so well, together we have a discussion and we decide, hey, should we even pursue a second one, right? Thinking about cost, thinking about outcome, and so forth. But most people, if they do well with that first injection, they're more than likely to do well, and then you're really going to be able to stabilize that joint. I've had people fall off horses that have just really nasty injuries of that SI, and you know, pelvic obliquities and things of that nature, and we're able to just do this injection. It's remarkable. It's kind of like what Michael saw in Norway, right? Like it's just kind of, you just see people getting healthier and better. A lot of athletes do this. In fact, they mix up the Prolo with PRP. Some people use it for CMC joint arthritis. It works very favorably. You know, dextrose, just simple dextrose from a bottle. You know, so question.
I'm curious if Prolotherapy or PRP would be an appropriate or successful treatment for severe neuropathy.
So the question was, does prolotherapy or PRP, is it useful for severe neuropathy? And so I would say a caveat with that, it depends on the type of neuropathy. If it's mononeuropathy, for example, if you have occipital neuralgia, like you have headache from the neck, you can actually use dextrose. You can. We call them perineural injections, and basically it's just injecting around the nerve, not in the nerve. But the concentration matters. It has to be 5% solution, which is a lower concentration solution because it inhibits one of the key elements called the TRPV1 receptor, which promotes inflammation and pain. So yes, you can use it. You can use it for cervical radiculopathy in that fashion. For So for peripheral neuropathy of the foot, it's not as helpful in my experience. In my experience, if we're looking at sort of non-invasive solutions, I would almost recommend things like electrical reprocessing therapy. There's a device called Calmari, which is sort of non-invasive. You could use that. Medications can be quite sedating, so those are not always helpful. And then stimulation sometimes has its role in that. And I mean like things like peripheral nerve stimulation or spinal cord stimulation. Unfortunately, I haven't really seen, you know, neuropathy improve with, you know, like PRP injections. And personally, that's not the first thing in mind. If you have neuropathy that's so bad that it leads to wound problems, then what's very useful is actually adipose-derived stromal vascular fracture. That you can actually use to heal the wounds from a diabetic ulcer and the like. So that's a little bit different than neuropathy itself. So I would say to you, not as much data there for that. But if you were to use it low dose or low concentration, prolotherapy might be helpful. Yeah. Other questions? So we talked about nerves, tendons, fascia.
Insurance. So you say PRP approval is not covered by insurance.
It's not covered by insurance. It's
What
out.
about the visit to the doc for consultation?
The consultation always is. Yeah, absolutely. And that actually is the most important thing, right? Like if you ever think, well, hopefully you get to the doctor and there's some really good discussion and there's time and you know there's these factors and the you know the relevant information is there. Your history, what you're experiencing, imaging studies, and then the physical examination to really check and say, yeah, I think this is what you're dealing with. And then I tend to provide the whole spectrum of care. I go through what's covered by medical insurance, what's not covered by medical insurance, what's least invasive, what's most invasive, and then everything in and between. And then we together come up with the risk benefits alternatives to what we're aiming to achieve. I will say which I feel is better for the patient if you were my family member, but at the same time, I also am cognizant of cost, right? So a lot of elderly individuals may be on fixed income, Maybe they're supporting other family members, and so they just don't have the finances. So we come to a resolution as to what might be the most beneficial for you at that point in time. And these are not like mutually exclusive, right? So if you do say, you just have to do an epidural steroid injection because you just simply can't afford the other stuff. If you're having a hard time, it may be that you do that, but you use a very low dose, or you just do a selective nerve root block using a very minuscule amount of corticosteroid, just until you can, do something different in your treatment paradigm, right? And so these are different things. Interestingly enough, prolotherapy was covered in the Midwest for the Blues, Blue Cross Blue Shield. Because they saw a lot of people decrease their use of opioids and avoid surgery. So it was popular at a time, and they were actually covering it, PRP was like that too at some point in time. But now they consider these investigational, and a lot of times you'll see it's physical therapy, which is very helpful, medications, some not helpful, right? Like we've all been on opioids or maybe have had the experience of that, and Neurontin and sort of these, neuropathic medications. Those tend to be covered by insurance plans and medication benefits. Then you have cortisone, and then surgery. So unfortunately, there's not much in between, but a lot of people are noticing complementary and alternative medicine, right? Like, so things like acupuncture, clinical evidence for low back pain, very effective, right? The use of a high frequency TENS stimulator, that can also be helpful for people. Maybe not, not so much the lower frequencies, but higher can be helpful. So you have a lot of things. Ultrasound, somebody mentioned ultrasound before. Heat and ice, right? Other modalities to help. Heat tends to be very good for people, like massage, osteopathic manipulative medicine or manipulative therapy, massage therapy, pelvic floor therapy, right? So these are all elements of care. Other questions? Yes?
Indigenous medicine men, have they ever used something like this prolotherapy? The reason I say, I was falling off a roof years ago,
Yeah.
injured my shoulder,
Yeah.
went to Kaiser, doing injections, I couldn't lift my arm.
Yeah.
My mom took me to this medicine woman
Yeah.
in Reedley, California.
Sure.
She interviewed me and discussed what happened. She went and got some herbs from her garden,
Yeah.
gave me a drink, and then she massaged, applied heat,
Yeah.
suction cups, more tea, and then she said, raise your arm. I said, I can't raise it. Raise your arm. I was able to raise my arm, and to this day, no problem.
Yeah.
And I often wondered, what did she do that Kaiser couldn't do?
Right, so it's a very good, it's more of a comment, right? Like, it's like a medicine individual who had treated using alternative, like herbs and heat and massage, right? Suction cups or what we call cupping, also very useful, right? All of these factors help, and lo and behold, in another maybe organized, closed health system, that was not the traditional treatment approach, and yet it worked, right? And so if it works, it probably is helpful. And if it's helpful, there's probably evidence for it. It may not be to the statistical significance of a controlled study, but it works, and it's probably worked for centuries, right? Like, and it still works. So people still seek it. And because we all have the aim of again, right? We want to get better, we want to improve our performance, we want to heal, and we want to be well.
Okay, I think we let Dr. Mesa go.
Yeah.
It's a work night.
Thank you very much. Thank you.
Sorry
Yeah.
about that.
No worries. Yeah, it's my pleasure. It's my great pleasure.
Always give him the
It's nice to be back. Yeah, see you folks. You're very welcome.
Very interesting. I just had a vertigo.
Very good for you. My mother-in-law had one and she was better in 20 minutes. My mother-in-law had one and she was better in 20 minutes. Very effective. Yeah. Did you have COVID?
I'm glad I had it, yeah. I mean, my T9 was in pieces.
Yeah. Glad it was effective.
And now I can come back now. They sent me to home therapy.
Yeah?
They said, and now I'm ready to come back here because that